Hello everyone, welcome back. Today I'll be covering tibia plateau fracture. These include fracture mechanism that can be divided into high energy trauma and low energy trauma. Investigation, personality of fracture, Schatzker Classification, the goals of treatment, indication for non-operative treatment, operative treatment, and conclusion. Now let's get started. Fracture mechanism. The fractures of the tibia plateau can be caused by a variety of forces. These include A. Varus or valgus deformation, B. Axial compression, C. Flexion or extension, D. Direct trauma. Regarding anatomy of the knee, the tibia is the weight-bearing bone of the leg. The tibia plateau has two articular surfaces, the medial and lateral tibial plateaus, or also known as the medial and lateral tibial condyles. The medial tibial condyle bears around 60% of the knee weight and is a thicker structure. It is concave in shape and located slightly more distally compared to the lateral tibial condyle. The lateral tibial condyle is convex in shape, thinner, weaker, and more proximal than the medial tibial condyle. The intercondylar eminence is a bony structure between the two condyles that serve as an attachment point for the anterior cruciate ligament. Lateral meniscal tear are common in Schatzker type 2 fractures and when there is more than 10 mm of articular surface depression. The medial meniscal tear are most common in type 4 tibial plateau fracture. ACL injuries reported in Schatzker type 4 and 6. Vascular injuries common in type 4 tibial plateau fracture and proximal tibia fracture. Fracture mechanism based on two groups. Number 1, young patient with good bone stock, usually due to high energy trauma. Number 2, elderly patient with osteoporosis, usually due to low energy trauma. High energy trauma always involve extensive damage to the soft tissue, contusion, open injuries, compartment syndrome, peroneal or tibial nerve injury, popliteal artery injury. For low energy trauma, usually is axial trauma, no contusion, close injuries, no or minimal soft tissue problems, axis deviation, fixation challenge is due to osteoporosis. For low and high energy trauma, please take note, in low energy trauma, the problem is mechanical. Problem in fixation in osteoporotic bone. In high energy trauma, the problem is biological and associated with damage to the soft tissues. Investigation. These include X-ray in two planes, 45-degree oblique, CT computed tomography, MRI magnetic resonance imaging, angiography. Regarding personality of fracture, need to identify the soft tissue damage, the degree of fracture displacement, degree of comminution, degree of joint involvement, any associated dislocation, the bone quality, whether osteoporosis present, nerve or blood vessel injury. Classification that I commonly use in tibial plateau fracture is Schatzker Classification. Simplified version, for Schatzker 1, lateral plateau split fracture. Schatzker 2, lateral plateau split depression fracture. Schatzker 3, lateral plateau pure depression fracture. Schatzker 4, medial plateau fracture plus or minus knee dislocation. Schatzker 5, bicondylar fracture. Schatzker 6, metaphyseal deficient dissociation or comminution or extension. This figure shows the tibial plateau fracture classification by Schatzker. In type 1 is lateral split, type 2 is lateral split with depression. Schatzker 3 is lateral pure depression. Schatzker 4, medial plateau fracture plus or minus knee dislocation. Schatzker 5 is bicondylar tibial plateau fracture. And Schatzker 6 is metaphyseal deficient dissociation or involvement or extension. Just an overview. To promote a more comprehensive understanding of tibial plateau fracture, a theory of three-column classification was proposed that particularly emphasized the CT and image reconstruction. The updated three-column concept was developed on the basis of fracture morphology and mechanism of trauma, and the criteria to determine the appropriate injury mechanism consists of 2 points: the position of the knee joint at the time of the traumatic event, at the exact relative position of the femur to the tibia, whether in extension, flexion, or hyperextension, as the initial position, and the direction of the deforming force, either varus, valgus, or axial. The goals of treatment: 1. Decompression and preservation of soft tissue. 2. Reconstruction of joint surfaces. 3. Reconstruction of normal mechanical axis. 4. To achieve early range of motion of the knee. Indication for non-operative treatment: no joint step off more than 2 mm, no axial instability, in severe osteoporosis bone, general and local contraindication, example, in high-risk medical patient that are unable to tolerate anesthesia, or patient that have contracture, or non-ambulatory patient, poorly controlled psychiatric patient that unable to take care of the post-operative wound that may lead to surgical site infection. I know it's controversy, but you can use it as a indication for non-operative treatment. For non-operative treatment, it consists of traction that may be used in short term, early active movement in a cast brace, touch weight bearing if patient condition allows, weight bearing to tolerance at 6 weeks. Non-operative treatment does well in a low demand elderly patient. In emergency operative treatment, these include vascular injury, compartment syndrome, open fractures, knee dislocation, floating knee, polytrauma patient. Decision making. The timing. Most surgery is best delayed. It allows time for special investigation, allow time for recovery of soft tissue that may up to 10 days, allows time to assemble the best implant and surgical team. In delayed surgery, the use of a temporary spanning external fixator will allow optimal recovery of the soft tissue while preserving the length and axis. Surgical approaches can be open or arthroscopic. The approach can be anterior or anterolateral, medial or posteromedial, lateral approach, mini-open. I already discussed in journal number 2, surgical approach to the tibial plateau fracture. Operative treatment planning. Whether you need a bone graft or bone substitute, the stabilization, whether you need a distractor, how many use are you going to use, the direction of the screws, how many plates are you going to use, one anterolateral plate, or lateral plate only, or posterior medial plate, or double plating, and hybrid fixator. Option of hybrid fixator for severe soft tissue injuries. It reconstruct of the joint surface, reconstruction of stable axis, early motion of the knee, and have an excellent result by if it's done by the proper surgeon. For LISS, less invasive stabilization system for proximal tibial fracture, helps in reduction of joint, fixation using a leg screws, restoration of mechanical axis, fixation of metaphysis using a LISS. This figure shows the LISS, less invasive stabilization system, whereby you insert the plate between the tibialis anterior muscle and the periosteum under image intensifier. The results of LISS, it depends on fracture type, depend on soft tissue management, depend on realization of goals, can be excellent event in high energy trauma, the average range of motion 0-320 degree about 87%, no deterioration in the second 5 years, good prognosis. Conclusion. 1. Proper analysis of the fracture mechanism and the concomitation. 2. Correct timing for surgical intervention. 3. Aim for absolute stability by anatomical reduction and rigid fixation of joint surface. 4. For relative stability, functional reduction and stable fixation of metaphysis. 5. Restoration of joint stability by appropriate soft tissue reconstruction. 6. Early active range of motion. Yay, we have reached to the end of this video. I hope it helps. See you in the next one. Take care and bye.